Todd Stottlemyer is the CEO of Innova Center for Personal Health. So give us the elevator pitch. What exactly does the center do?
So the Innova Center for Personalized Health is part of the Innova health system, and it's really an inside-out disruptor. We have this 117-acre campus, formerly the headquarters for ExxonMobil, and the whole focus is on personalized health, and that's different from precision medicine, because fundamentally what we're trying to do, how do we keep healthy people healthy in the first place? How can we better predict and prevent disease? And if you get disease, understand the molecular biology of the disease so we can treat it with a very targeted therapeutic. So it's different when you think about the healthcare system today, which is really a sick system. That's what we do now. We treat sick people. And this is really how do we keep healthy people healthy in the first place.
Mm-hmm. Some of the conversations I've had with health IT leaders point to a future where it's more about treating the patient at home rather than filling hospital beds. Can you talk a little bit about that?
Yes, I was with the healthcare system for a couple of years, left, went back into the technology space, but I had a futurist who worked for me, and he, this is 2009, he drew this great picture. He said the healthcare system of the past, at the center was the hospital, and then you had spokes. He said the healthcare system of the future, at the center is information, and the hospital is just one of those spokes, because more and more care is being done in what we call ambulatory settings outside the hospital, or it's being done in the home. So there is a real transition that's going place and very different thinking about what is the healthcare system of the future, particularly with data and information coming from so many sources outside of the healthcare system.
So what will be the biggest difference between the healthcare system, you know, the yesterday's healthcare system as opposed to the future one?
Well, I think, you know, again, a couple things. One, focus on health versus sick. And again, people are still going to get sick, unfortunately, but that reorientation about how do we keep healthy people healthy in the first place. And then secondly, you know, again, more and more being done outside of the healthcare system. You know, we've gone through in healthcare, I mean, the first big thing was around digitization of records, electronic medical records, and you know, centralization of data, standardization of protocols and processes. I mean, that's just making the pipes work both inside the healthcare system and the interoperability with data outside of the healthcare system, because that was kind of the first big thing. The second thing now is really the proliferation of data. And it's both the types of data, phenotypic data, genotypic data, sociodemographic data, data that's coming, you know, from lots of different sources, and also where that data is coming from, because it's not just coming from inside a healthcare system. It's data that comes from outside the healthcare system. It could come from devices, it could wearables, and those types of, you know, the Internet of Things, generating very important data that can be actionable when brought together with other data to make that actionable information.
Where do you see the largest growth when it comes to investing in emerging technologies?
You know, I think there's, you know, I'll talk two ways. I think there's diagnostics, you know, gene technology, gene sequencing, gene editing, which is obviously a fairly controversial subject today with CRISPR technology, targeted therapeutics, you know, something very important. How do we, again, understand the molecular biology of disease, and how do we target that disease so we treat you as an individual, not as a population class? The virtualization of health. Alan had a good question earlier. I mean, one of the challenges we face today is that the science and technology is running much, much faster than the ecosystem, the public policy ecosystem, the payment ecosystem. We have, you know, basically 50 systems of virtualized health. I sit on a virtual health company board, so I think that's a big opportunity as well.
Is that one of the reasons you guys decided to launch an accelerator as well?
So we've, we launched something called the Innova Personalized Health Accelerator, really a kind of a three-part effort. First, we have a free education initiative around entrepreneurship, really trying to increase entrepreneurship in the health sector. Secondly, we did launch an accelerator. And again, how do we increase the innovation quotient inside the health system by taking nascent and other types of technologies and then applying those inside the health system? And the third thing we did, we created a venture fund. We actually created a $150 million venture fund to invest in technologies, again, around adoption inside the healthcare system. So we're very much trying to drive innovation inside the healthcare system, a lot of intellectual properties created, as you can imagine, inside the healthcare system, and then be much more intentional about how we interact externally. Healthcare as an industry, and some of you are in healthcare, has not been particularly good at looking at other industries and how we can adopt things that are being done in other industries inside healthcare. So again, we're really trying to increase the internal innovation quotient and make us much more externally aware of technologies that could be applied internally inside the healthcare system.
Could you maybe mention some of the initiatives that have come out of the Accelerator? What are they focusing on?
Well, we just launched the Accelerator. We launched the venture fund about a year ago. So we've made a number of investments in devices, particularly we're going first in human type trials, and a lot in analytics. You know, one of the emerging technologies that I probably to mention, we are very, very focused on predictive analytics. I mean, how can we predict sepsis? How can we predict who's likely to readmit? How can we predict who may be more likely to fall? Because those are big issues. How can we better engage with those who've been inside the healthcare system, go outside the healthcare system? How do we make sure that the medication adherence and you know, diet, which has a big impact on health? So, I mean, predictive analytics is an area where we've made a lot of investment, and I think we'll continue to make investment both internally and also with external partners.
What has been some of the key takeaways in adopting that kind of technology?
In terms of predictive analytics? I think we're still very early. I mean, healthcare is an industry, and this is me editorializing, but I think we were late to the game in terms of really adopting information technology. I mean, with meaningful use, the big push around electronic medical records, electronic health records, and really that's just to make basic data workflow you know, move within the healthcare system. I think one of the big challenges is that so much important data, as I mentioned earlier, is coming from outside the healthcare system. So how do we take data from various sources and bring that together and turn it into actionable information that can improve clinical outcomes, quality, safety, the patient experience? We're still in the very early innings. I like baseball. I'm a Yankees fan, so I apologize for anybody who doesn't like the Yankees. But we're still playing, by the way. And we're still in the very early innings of this, because we were late around the adoption of information technology. We're still working out. We like to joke, we implemented Epic, that Epic's a four-letter word, both literally and figuratively. And if you've implemented Epic, you would understand our pain. Good system, tough system, not an easy system to implement, but we're still very early in the, I think, the adoption of information technology. We're very early, I think, in how do we take, and I don't like the term big data, because I think data is interesting, but it's not relevant unless you can turn it into actionable information. So how do we take phenotypic data, genotypic data, data outside the healthcare system? I mean, the holy grail for us is kind of that longitudinal look at a person's health, not sickness, but a person's health. How can we better predict and prevent disease? And again, if you get disease, how can we make sure we target your specific disease based on what you have as an individual? You know, another exciting area for us is what we call the area of pharmacogenomics, which is the intersection of pharmacology and genomics, and the ability through a sequence, just to take a sequence right here, cheek sequence, and run a sequence on you, we can come back and we can tell you how you will metabolize certain drugs, and so dosing levels and toxicity, because we don't want to give you a drug if it doesn't work, and we certainly don't want to give you a drug if it has high levels of toxicity. Again, one of the questions earlier about the ecosystem having to catch up with the science and technology, a lot of those tests that have high evidence, high efficacy, certainty, if you will, around drug metabolism and toxicity, they're not reimbursed today. So I'll give you a real life example. Somebody had his knee replaced down in Florida, and he spent several days, additional days in the hospital.
Is that Congressman Connolly?
No, it's not. And we never identified the person. But he had knee replacement surgery, and he ended up bleeding. And this was not in our health system, but bleeding profusely. And it took, you know, a lot of work, and he spent 3 or 4 extra days in the hospital. He's fine, thank goodness. But he came back north and had our pharmacogenomics test. One of the drugs in that panel is Coumadin, warfarin, which is a blood thinner. And it showed that he should never get warfarin. Now that $400 test today is not reimbursed. Now if he'd had that $400 test before he had his knee surgery, they would have never allowed him to be on Coumadin or warfarin, because they knew it had such an adverse effect today. Now his time spent in the hospital cost tens of thousands of additional dollars. Today that was reimbursed by Medicare, because he's over 65. But that $400 test is not reimbursed today, even though there's absolute clear scientific evidence that we can tell you that he should never have been on Coumadin or warfarin in the first place. So the ecosystem has to catch up to where the science and technology are today, and more importantly, where it's going tomorrow.
What are some of the technologies that you personally think have been most disruptive in changing the healthcare sector?
Well, I'll give a big shout out. I was recently with Dr. Eric Green, who runs the NIH National Human Genome Research Institute, and as you know, around 1990, we started this remarkable project called the Human Genome Research Project to see if we could map the human genome. It took 13 years, and we mapped the human genome, and there's a lot of debate about whether or not we should invest in basic science and research as a country and government, and I'm a big proponent for that because we spent about $3 billion to map the first human genome. So how much does it cost today to get a whole genome sequence? Anybody know? Any thoughts? About $1,000. That's exactly right. The first one cost $3 billion.
Wow.
Today, $1,000 whole genome sequence. If you accompany that with pharmacogenomics testing, you can get a real interesting, start to get a holistic look of a person. So I would suggest a great investment by the federal government. And as a result of that, if you look back 7, 8 years ago, the number of personalized precision medicines was in about a dozen or so. I mean, now there's been an exponential increase in the number of precision medicines that give real hope. I mean, again, we're in the business of improving the human condition. They give incredible hope for certain types of people with certain types of diseases. Lung cancer, certain lung cancers, melanoma, that if you were a stage 4 melanoma patient or lung cancer patient several years ago, you had no hope. But some of the work, the immunotherapy work that's been done, again, because of this significant investment that we made to better understand the human genome, I think has really been spectacular. And again, we're just in the very, very early innings of what this means in terms of precision medicine and better understanding the molecular biology of disease.
What role will something like artificial intelligence have in actually getting to that point where you understand more of that?
Well, I mean, artificial intelligence, as you know, it's been around for a while. It's not a new concept. It's been around for some time. I was talking about some of these questions with one of my colleagues, and he said, you can replace the chess player with a computer. That sounds okay, but would you replace the physician with a computer? And the answer is, in some things, probably yes, particularly radiological reads and things like that. But I think our view is that artificial intelligence is really going to help in decision support and really aid human interaction with patients. So I think it's a supplement to and will really help, again, with our objectives of how do we improve clinical outcomes, improve quality and safety, and be very precise with treatment. So I don't think it's a substitute for, I think it's a complement to.
You mentioned to me prior to this event that you could use AI to help radiologists actually read the x-rays, and that takes seconds rather than having someone actually look at the x-ray and trying to interpret.
And you get higher accuracy too. So I think, again, there'll be some substitution, but this is not something where you're going to show up and a physician's not there. I think it really is a complement to, an additive to the whole opportunity. And again, I think one of the earlier panelists talked about this proliferation of data. I mean, data by itself is interesting, but not necessarily relevant. And so again, how do we take all this data from various sources, and not just the information that we typically think about health, but we know that socioeconomic data, we know that environmental, we know there are lots of other types of data that is very impactful on a person's health. So how do we get that longitudinal, holistic look at a person's health so again, we can be able to better predict and prevent? I mean, again, if we can predict and prevent disease, obviously we're in a much better place than we have to treat disease. And again, that's this focus on personalized health, not just on the medicine, the sick part, which is really the healthcare system that we have today.
Mm-hmm. And with the expansion of the ecosystem of connected devices, how are you looking at security of data and devices differently?
Yeah, I mean, security is a big issue. And again, I think healthcare, we had this rush around meaningful use. We want to digitize records, which sounds like a great thing. We want everything electronic. We want workflow. We want interoperability. That's great, right? We're all for that. Well, we probably didn't do a great job when we were thinking about architecture up front once we were doing that around security. And one of our security folks likes to joke that I think the original architecture design was once you were through the front door, the dog was kind of sitting there and tell you where the safe is, where all the valuables inside the house. And I don't think we really thought through that as well as we needed to initially, again, because there was such a push to get to digitization of records, to centralize data, to provide standardization of protocols and such. So today, it's a huge issue. I mean, we've seen obviously enormous number of breaches inside the healthcare space. It's something that we spend a lot of money on, that we focus on very hard because we possess, obviously, a lot of interesting information about a person's health. And it's also certainly a real interest at the board level, too, to make sure that we can protect that data and that information. And it's not just for nefarious purposes. I mean, one of the, again, going back to the ecosystem, you know, if we want people to do genetic testing, we want people to use the power of genomic science to be able to better predict and prevent health. But today, the ecosystem that exists, you cannot be discriminated for purposes of health, and you cannot be discriminated for purposes of employment. But a life insurer or a disability insurer can choose not to underwrite a policy based on information that you may have from some type of genetic sequencing, right? So, I mean, that information today legally can be used to discriminate against somebody. So again, the ecosystem has got to catch up. So it's not just nefarious purposes and use of information. It's also that information legally can be used to discriminate against you. So again, that ecosystem has got to catch up to the science and technology.
Mm-hmm. And it seems like the move when it comes to healthcare is really to empower the patients and give them the power and the encouragement to manage their own health. So where do you see that going within the next few years or so? Will there be a need for hospitals, doctors?
Well, unfortunately, disease is very, very tough, and there will be a need for hospitals and doctors. I think one of the questions is, you know, again, thinking back to that futurist who worked with me for me about 10 years ago, his whole point of view, again, information's at the center, not the hospital. And I think he's right. Also, I think at the center really is the empowered consumer, the empowered patient. I mean, who owns the information? I would argue that really is the person, the individual. It's not the healthcare system. It's not a hospital. We're just one of the plug-ins along the way. But that care is going to be done in so many different places, both inside and outside of healthcare system. It's really the consumer that should own their health information, and the integration of not only their health information, but other information that's relevant to their health should be that empowered consumer, in my view.
And the center is really on the cutting edge when it comes to technologies. So what are some of the focus areas in 2018 and going beyond 2018?
Well, I think on the science side, it really is around this precision medicine. And again, how can we use the power and the discovery around the human genome and genomic science, and not just genomics, but proteomics, which is a subset of omics, proteins and genes. You get to go back and do some biology here. But how do we use that to more precisely treat disease? And then how, again, can we use the power of the science and technology to be able to better predict and prevent disease? I mean, to give you a kind of what's different today, if 10 years ago, if a 40-year-old mother presented with breast cancer, obviously we're going to focus on her breast cancer and come up with a therapeutic. But today, with the understanding the advances in science and technology, the first thing we're going to do is we're going to sequence that tumor, because we want to understand the molecular biology and characterization of that tumor. It's actually less important today. Oncologists will tell you where your cancer is than what's the molecular signature, if you will, of your cancer. So we want to come up with a very targeted therapy and approach to her disease. Well, what if she has two daughters that are 22 and 24? What if her mom had breast cancer, her sister had breast cancer? So those two daughters have a mom, a grandma, and an aunt who've had breast cancer. I mean, today we would advise the 22 and 24-year-old to go through genetic testing and to see if they have a BRCA1, BRCA2 gene. And then obviously that's information that's very relevant to their health. So if they were to come back and test positive, we know that there's going to be a much higher likelihood that they can develop breast cancer. Now, what we can't tell them today is when. So it's not just providing data and information, it's providing data and information in context. So we would make sure that they would have genetic counselors, working with them to help them make informed decisions. And those informed decisions could include just much more active monitoring, or they could make a decision to have a double mastectomy with reconstructive surgery. I mean, that's a big life decision. And so giving people information without interpretation and counseling is a wholly bad idea. So we don't do that. We don't provide people genetic information about themselves without providing with genetic counselors to make sure they can understand the information and their options and make choices that are personal to them. That's something very different. Before we mapped the human genome, we wouldn't have had that capability. It's now something that we would do, again, treating not only the person who's sick, but also trying to keep those two other individuals, those two young women, from getting breast cancer in the first place, and that's the focus on health.
So what's next for you, and what are you planning on addressing? What will be your key area of focus in 2018?
Well, so we have this 117-acre campus that we're in the process of going through significant renovations to the existing footprint and then developing the campus over time. Our objective is to create a major life science, bioscience, international hub of innovation and discovery on this campus. You may have seen about a year ago we announced an important partnership with the University of Virginia, a medical education partnership, a research partnership, and also innovation partnership. And we really see taking our clinical capabilities, our research capabilities, in conjunction with UVA's clinical research, medical education capabilities, and then other life science, bioscience entities, data, technology companies, and building out our own version of Kendall Square right here in the greater Washington, D.C. area.
Nice. So we'll take a couple of questions from the audience. Do we have our mic?
Anybody want to talk about molecular biology?
Okay. Steve.
I have a question. There's a lot of talk on the Hill here about revising, changing, repealing, whatever, the Affordable Care Act. Does Innova Hospital have any opinion on this? I'm sure you're monitoring it. And the other sort of part two of that question is, how would you characterize your relationship, a private sector's healthcare relationship with public sector healthcare folks?
Well, the second question is the public sector is terribly important because of this entity called CMS, which has not only Medicare and Medicaid, but has a big influence on commercial payers and how they look at reimbursement. So there's a very tight integration, I think, just given how powerful the federal government is in the health marketplace because of Medicare and Medicaid and how commercial payers will follow a lot of what CMS does. So there is a tight integration. Obviously, we are a heavily regulated industry as well, so certainly the federal government, the impact of what the federal government does has an impact on us. On the Affordable Care Act, I mean, it's interesting because this is not to be political, but it did start to really change behavior, and I'll give you an example. Discharge, when you were discharged from a hospital, I mean, it was essentially a financial function, kind of a settling up, if you will, of who's paying for what, your insurance and so forth. And you did get discharge instructions, certain instructions related to your health. But truthfully, we were probably less focused on that. I mean, again, we were good stewards and gave people medications and things like that. And once you left the hospital, you went back to hopefully heal within your home. Well, this thing called avoidable readmissions, that if you come back within 30 days to a hospital, there's some presumption that it was an avoidable readmission. So that really changed the thinking around discharge. It wasn't just a financial function, it was a continuum of care, continuity of care function to make sure that once you left, since medication adherence is such a challenge in the United States for patients and in the world, but to make sure you're taking your medications, the right medications at the right time, to remotely monitor vitals, right, your health, to make sure you're following up with follow-up appointments. So we became much more engaged and much more intentional once you left our health system to make sure that you were continuing to get better. You were doing the things that were important to your health around medication adherence, understanding where you are from your health itself, follow-up visits and things like that. I mean, that was a big change because the impact of not doing that, if people come back, it's a cost to us. No revenue, so it hits directly the bottom line. So, there's an example that I really think forced us to think differently today. A big concern that we have is pre the Affordable Care Act that the really entry point to a healthcare system was the emergency room. It's the most expensive form of care. Most people that used to go there shouldn't be there. I mean, really ought to be acute types of things. But that was the entry point. That's a very, very expensive point of care for people to enter a healthcare system. So I think there's been more rationality since the Affordable Care Act. And so we're concerned. I think we're all concerned about, there are issues. Anytime you pass a major piece of legislation like the Affordable Care Act, some things with the benefit of hindsight are going to be good, some things with the benefit of hindsight are not, and you should be open to changing and modifying the things that don't work. But the idea that you scrap it with uncertainty about what's coming next, obviously that's a concern for all healthcare providers in the United States.
One more question?
No molecular biology question?
Now you've scared them.
Over under on the
Yankees in 6. There you go.
Amanda?
Severino's going
You
to
have a
pitch well tomorrow night. With a name like Stottlemyer, this will show my age. You know, he pitched for the Yankees a long time ago.
Amanda has a question here. The reporter with us.
Yeah, so what challenges do you face when you're trying to implement these technologies that you say face challenges with the environment that healthcare is in today? Do you face any challenges in your
I mean, we face, this is a huge change management. That's why I say it's kind of inside-out disruption. Because again, the healthcare system has principally been a sick system. You know, we treat sick people. It's been very transactional. We see you when you're sick, but this holistic approach to health, it really includes when you're healthy, not just when you're sick, and not just transaction-based, is very, very different. So there's enormous change inside a healthcare system. And when you talk about things like genetics and genomics, even with exceptionally talented men and women who are clinicians, you know, their genomics and genetics was about that thin in medical school. So, for example, on the pharmacogenomics side, one of the things I'm very proud of at our hospitals is, as part of the standard of care for any newborn baby born at an Innova hospital, you have the option as parents to opt in to have a genetic test, a pharmacogenomics test done in your newborn, just a cheek swab, and it can, you know, I think there's 7 genes, 21 drugs, and we can tell you, the parents and a pediatrician, that early on there may be some drugs that that child shouldn't take. An example is codeine. That's one of the drugs in the panel. Codeine is a drug that's given to young children for pain. You know, codeine can have certain outcomes. It can work, no side effect. It can not work, right, and not have side effects. Or you can have terrible side effects, including death. So why would we ever give a young child codeine when we know we can tell them whether they should take that drug or not? So the democratization of genomics is something that's very important to us, because I think one of the concerns is that this is something that's going to be available only to people of means. And so we've really tried to push in the democratization as well, so that, you know, in this instance, all babies, regardless of their parents, have access to something, if they choose to do it early on in life, that starts to, you know, begin to give a more holistic picture of their health going forward.
And it's
But it's a
interesting.
huge change management, both inside the healthcare system and outside. And just make one last comment. I mean, the payers, for example, the insurance companies, and when you meet with them, they're honest. How much experience, understanding do you have genetics and genomics? And they'll go, about right here. So again, the science and technology always runs faster than public policy. It is galloping ahead of public policy when it comes to what's going on in the health space today.
It's interesting to see the rise of companies like 23andMe. You can actually swab your cheek and send it out, and for a couple of $100, you'll find out more about your DNA and things like that. Food tolerances to food allergies. I think it's amazing. Well, thank you so much for taking the time. We really appreciate it.
Thanks for having me. Go Yankees.
Yeah.